All right, so now we've reached a portion of the CE about biceps tendinopathy. And the reason we use tendinopathy is because really this could be a tendinitis or a tendinosis, depending on how long it's been going on. So the things that I want to bring to your attention is that we really do have a long head and a short head of the biceps. So your long head is the thing that we're mostly focused on, as a short head really is not susceptible to any kind of tendinopathies. The long head is the one that goes through the intratrabecular groove, or we maybe sometimes call the bicipital groove, goes underneath the transverse humeral ligament, which you're going to see right here, and then actually 50% of that tendon goes into the top part of the labrum, and the other 50% goes onto the glenoid tubercle. So we have a bony attachment and also a loose attachment to the labrum. Hopefully that's a tight attachment, but sometimes what we see with repetitive stresses is it can cause detachment from that bony rim of the labrum, and which we would call a slap lesion. So biceps tendinopathy normally affects the proximal portion of the tendon. So just beyond the transverse humeral ligament, just above that, right in this area, it's going to see a lot of friction. And what we can see is the tendon is going to change its course of action. It is going directly down into the arm, and then right there is taking a 90-degree turn. Of course, it's not exactly a 90-degree turn when you look at it in the body. So we really need to look at the function of this, is that just being above the humeral head, it does have a primary stabilizing action as far as the glenohumeral joint. So we can see the losses of humeral stability can also pull at this insertion point. Now, when it comes to the anatomy, we really think about the labrum as a meniscus. If you remember from the SLAP lecture, that this can detach. This superior labrum is a meniscus-like. It's not very vascular, so when we do have problems here, and that circumferential rim of fibrocartilage starts to pull away from the labrum, then unfortunately you can have irreversible damage. The good part is, like we saw from that lecture, is 50% does attach to the actual bone, so there is a good bony attachment. Unfortunately, in today's world, and I guess I shouldn't say today's world, it's been this way for many years, we have people who like to do this. That's me about 3 weeks ago when I was training for a bodybuilding show. Just kidding. And we have people that do repetitive stresses. Now, the bicep is not a common injury when you look at the entire population, but it is a very prevalent injury when you have a particular sports, weightlifting, or activities or jobs that require repetitive elbow flexion. So that's one thing we want to take into consideration in these kind of patients, is what they do for a living, what their sports, what their hobbies are. As far as biceps tendinopathy, we see this happen a lot with increased physical activity. And in fact, 95% of people with biceps tendinopathy also have shoulder impingement as their primary diagnosis. This doesn't mean they have two things going on at the same time. They have one thing going on at the same time, and that is glenohumeral instability. And unfortunately, the ball, the humerus, is rolling up into that squishy stuff up top. It's getting pinched between that and the coracoid on top, and now we have irritation of tissue. So we really want to make sure that we understand that when you have issues with your biceps, 90% of biceps tendinopathy presentations happen with other impingement type pathologies. And now we see a lot of nocturnal symptoms associated with all shoulder injuries. There's two pieces to that puzzle. I'm sure there's more, but there's two pieces that I think are readily explainable that I talk to patients a lot. The first one is sleeping adds compression. If you're sleeping on your shoulder, if you're sleeping with your arm across your body, it can really aggravate things in the shoulder. The second piece is when you sleep is when you heal. So of course, when you're trying to sleep, your body has nothing else to do besides throw down some inflammation everywhere there's a possible injury. So that being, this, as far as this case, in impingement type areas. So we have these kind of pains. It can refer to the deltoid insertion. Remember, cervical disc lesions can also refer to the deltoid insertion. Tests like the arm abduction sign, tests like arm squeeze test can help eliminate the cervical radicular symptoms as compared to the shoulder symptoms. Now, when we get into these kind of tendinopathies, what I find, and I've seen a staggering amount of these in practice, is this: when you actually see something called a Popeye sign, and that's when you can see tearing of this tissue. I was in a gym when I saw this actually happen on someone. It was the oddest thing I've ever seen while weightlifting, but he was lifting with a preacher curl, and he let out a scream, but he said it didn't hurt, and you could see like a quivering in his arm, and then that muscle ball up, and it wasn't like a rubber band that would snap up. It slowly started to compress and contract. The odd thing about that is that he said it didn't hurt. He said it felt very weird. However, he wasn't in excruciating pain. I've had several of these in my practice, not while weightlifting with someone, but after the fact. And a lot of times I get the same symptoms. This is not my patient. However, I have seen arms that look just like this. And the thing that's strikingly odd about these kind of bruises and pains is someone will come to your office and say, yeah, I've got this bruising and my arm is a little bit achy, but it really wasn't that sore. Do you think this is a big deal? Well, there's two parts to the story. Yes, it was at one point. However, you've got maybe a day or two if you're seriously thinking about surgically repairing these things. Otherwise, they will start to retreat back toward the origin, and it's not a surgical case anymore. It's more of a cosmetic case when it comes to an actual rupture of the biceps. So yes, it is a big deal. We need to explain to our patient, educate them on what happened. But if it's been 2 weeks old and they're 70 years old, unfortunately, there's not a lot we can do for these types of patients. So biceps tendonitis, when we do a lot of activity, normally we're going to have that just above that bicipital groove near the exact same spot that we're going to have impingement type syndrome. If it's a tendinosis, that means it's been there for a long period of time. They have a job, they have an activity, they have a sport that aggravates it. They're still going to have that tenderness right in that area. In fact, my wife had that a lot after when our kids were young. She did a lot of picking up and moving the kids, and she had a lot of tenderness and soreness in that area. So kind of taking the diagnosis in consideration with the age of the patient and also their activity level will help you formulate a diagnosis like biceps tendinopathy. Now, the real question is, how do we diagnose it? So, of course, we've seen these charts before, the evaluation. What are the most sensitive and specific tests that we can use to diagnose a biceps tendinopathy? And then go into the actual treatment. When we have a tendinitis, something that's very inflamed, sometimes we're going to use more just stretching and isometrics. If we think it's more of a tendinosis, then we need to actually rough it up a little bit, create a controlled inflammatory response, and go ahead and do some strengthening exercise, which we'll see at the very bottom. So first, let's go ahead and diagnose it. So Littman test is when you're actually going to palpate the bicipital groove, and as you're palpating it, you're going to take her hand through internal and external rotation. When you have pain that's right there at the bicipital groove, this is called primary biceps tendonitis. It's responsible for only about 5% of all cases of biceps tendonitis. So that's going to be the most common test that we're going to use right there. Now, I think this is possibly the easiest test and possibly the most fun when it's your wife doing the exercises. We call it the uppercut test. And the uppercut test is just that. She's going to try to uppercut herself in the face. The cool thing about this is easy to do, it's easy to replicate, and it reproduces her pain. Now she pulls just because she's married to me and she knows that I'm probably going to let go and she's going to smack herself in the face. However, what you want that patient to do is when you hold there, she's trying to quickly bring her fist to her face. That quick motion, coupled with you holding it in one spot, eccentrically loads that biceps tendon, and in the case of people that have the diagnosis, exacerbate their pain. You really want to make sure it's a quick motion though. It will aggravate their symptoms. Now, think about that though. Somebody in shoulder pain, do they really want to do a quick jarring maneuver? Probably not. They're going to have a little bit of apprehension. Now, what I usually start with would be more of a speeds test. And this is, the only reason I'm going to start with this is because I'm already in this position. People with lateral shoulder pain are often going to have the same symptoms, that anterior lateral shoulder pain. So I do an empty can test, and then this would be the full can test. Now, full can is more in the scapular plane, while speeds test is more at 90 degrees flexion. And you can test it in the beginning part of that with the palm up towards the ceiling. You can also go palm down, and it would be the empty can position for the supraspinatus. Jurgensen's test is the exact same thing as the uppercut test. I don't think it's quite as good of a test. This is a slow bringing your palm to your face, essentially. Whereas the uppercut test, I think, might highlight dysfunction a little bit faster and easier. So this is a slow concentric motion as compared to the uppercut test, which is more of an eccentric load when she's trying to push and you're slowing her arm down. Now, this is kind of the interesting thing, because we're going to get into two tests that are actually for the subscapularis. So the belly press and the bear hug. However, what we know from these tests is that when we're trying to move the arm against resistance from the practitioner, is that it's really going to highlight shoulder dysfunction. And the subscapularis is really good at holding the glenohumeral joint down, and the biceps is really good at holding it, compressing it, and holding it down. So they kind of overlap here. The belly press test is, we saw this with the rotator cuff talk. So the hand's going to be on the stomach, and you're trying to pull away, and she's trying to hold her, stabilize her own shoulder. Reproduction of pain in the anterior lateral shoulder is positive for possibly subscapularis involvement, but also the biceps. And the same thing with the bear hug test. And the bear hug is also a test for the subscapularis, but can be used for diagnosis of impingement syndrome. Biceps tendinopathy, because they do serve very similar roles with holding the glenohumeral joint down. When it comes to me, I always look at the literature to say, what can I save my time, save minutes, save seconds with patients. What is the best test? What are the most sensitive tests? And when it comes to that, the most accurate is that uppercut test. So when we do that test and it reproduces pain right there, then we can usually be we certain that's more of a biceps type problem. Whereas these tests can also have a lot of overlap with an impingement type diagnosis. Now, the tests that we can use to document an impingement syndrome are what? We have empty can test, we have Hawkins, Kennedy, and also have Neer's test. So if you can do Hawkins and Kennedy test and see what's going on there, if they have positives with that, then more of an impingement syndrome. And those patients would not have pain with the uppercut test. Now, what we said in the beginning of lectures, they could have everything. There could be a lot of things going on. And what I normally find in practice is that some of those are going to start to disappear faster than others, meaning you can have a positive uppercut test and a positive Hawkins-Kennedy Neer test. Go ahead and do your treatments as far as stretching out the hypertonic structures, doing manipulation, and then by your first re-examination, you do your tests over, and maybe the uppercut test has gone away, but they still have a positive Hawkins-Kennedy. So don't be afraid of having two diagnoses in the shoulder. A lot of times people do have multiple diagnoses. Now, one thing that we need to really focus on is that when we're doing treatment of the biceps in a tendinopathy model, is that tendinitis requires being nice to it, being icing it and not using it. Whereas a tendinosis, something that's been there for a long period of time, is chronically irritated, that's something that we do want to rough it up. So in that case, I'll show you how we actually do some techniques that can create a controlled inflammatory response. So as far as stretching it and relaxing it, I think soft tissue manipulation works quite well. Where you see here, these red X's are where you're going to see the most common trigger points for that area. You've got the long head and the short head there. This is pure for educational purposes. I don't mean to insult your intelligence with drawing the biceps on there. However, you can do some movement stripping with just using your thumb and taking the muscle from a short into an elongated position. And I think this works well. But for me, for two joint muscles, my big muscles like the biceps, I do something like this, which is more of a contract relax. Just going to push your hand into my hand, hold for 7 seconds, relax, and then I'll bring it back a little bit further. Doing 4 to 5 sets of contract relax stretching works well to help give a little bit of length and desensitization of that muscle. Now, if somebody has more of a tendinosis, I can actually rough it up a little bit. So in this case, we've got the long head of the biceps. That little red thing right there is my intertrabecular groove, my bicipital groove, where we're going to find most of our primary issues with the tendon if there is some degeneration there. So I need to create some inflammation. I do some exercises, put some tensile strength or strain across there, and I use an instrument for that. I like my fingers a little bit too much. I use them all day long, so anytime I can give them a break, I will. I can use a tool. Now, of course, I do some lotion. This is for demonstration purposes only. If you go along the fibers of a tendon or a muscle, it's sedative to that area. If he goes across friction, then it's going to increase some inflammation to that area, whether you use a tool or a thumb or what have you. So we need to make sure we know what we're trying to accomplish. A tendinitis might respond best to longitudinal massaging, whereas a tendinosis is going to require you to get in there and rough it up a little bit, whether it's with a tool or not. There's a ton of different tools in the market. I'm not sure there's the best one or the worst one. I think that there is a lot to be said about taking some of those classes, though. Whatever ones you want to take as far as Graston or Factor. I think Rock Tape also has some tools. It's just learning about the muscles, learning about the most common sites for irritation, timing, duration, that kind of stuff. I think would be a good idea when considering to use any of these tools instead of just picking up a couple butter knives and rubbing it on people. Mobilization of the glenohumeral joint, we're not going to play this video. We've done it a million times by now. However, just mobilize in fact, I will play it while I talk. However, you really want to take a look at both sides when you're doing any kind of treatment to any part of the body to look for discrepancies, to look for compensations. So a lot of times with biceps tendinopathy, as we know that 90% of them have impingement syndrome, we're going to see loss of internal rotation. So that's one thing that we're going to want to attack. Treatment for biceps tendinopathy is pretty straightforward, which is why I love it. So biceps tendinopathy, when I see this, to be completely honest with you, the number one treatment is, hey, Bob, what are you doing now? Let's go ahead and stop doing that. Let's at least give this tissue 2 to 3 weeks of a break before we get back into whatever activity you were doing. And then once we find out whatever that activity is, once the pain starts to die down, I'm going to dive into that activity to see if I can find a way to put less strain across that biceps tendon. Because unfortunately, if they keep on doing whatever that offending activity was, then really nothing is going to change, or they're kind of peeing in the wind. So we have to calm things down before we build them back up in most cases. When I do this, I will take a look and I will do some biceps, cotton pendulum. And the reason I like this exercise is it just gets things moving. With most cases, when there are biceps tendinosis or even an itis, we can throw a little bit of motion in there to increase blood flow to get things to clear out and get the pain to go away. Movement does a phenomenal job at getting rid of people's pain. We know that as chiropractors, keeping your arm dangling there, maybe using a light weight if they can tolerate it, helps bring some blood flow to the area. With all the other classes, we've seen more bilateral stuff, but in this case, I do mostly a unilateral stretch. This is a bicep stretch I think works well. I do it against the wall, and I do this for one reason, is because a lot of times people have a shoulder pain, they're really uncertain about stretching it because it hurts. So she can push into the wall, which she's doing right now, and then you can see her rotate her body. So she's not actually moving her arm at all. Actually, her hand is now the origin, so she's switching origin and insertion, and she's able to stretch the biceps out and hopefully take away some of that pain and elongate that muscle, pull at those pain and pressure receptors, and get them to relax a tad. So the unilateral stretch works well. If you want to do both sides, obviously more than welcome, but this is usually a unilateral type problem. Even when you look at the literature, not so much just in ChiroUp, you find that a lot of biceps issues start with the base, which would be in the scapula. So the more we can create a firm, stable base to the scapular stabilizers, the better off we're going to be. So I still try to get them into a better posture. I do my cervical retractions, I adjust the upper thoracic spine, and then I always marry that to this exercise being the YTWL. When you can do all these things in conjunction, it can open up the shoulders, strengthen the scapula, get them in a better posture, and eliminate the signs and symptoms of both biceps tendinosis and also impingement syndrome. Now, if they do have more of a tendinosis of the biceps, the exercise of choice is normally this one. It's eccentric strengthening of the biceps tendon. This can be done with a pretty heavy weight, even on a smaller female. We can go ahead and do just the eccentric phase of the biceps. She is going to lower her hand, and then you can even at the very end, you can bring her all up to shoulder flexion also. So remember, the biceps tendon not only goes into elbow flexion and extension, but the bicep goes all the way to the glenohumeral joint. So you can even add in, if you wanted to, even shoulder flexion and then going down into that range of motion. The research is 50-50 on that, whether you need that or not. But normally I'll start people off just with the elbow flexion part of this. And the reason I think that's a little more beneficial, at least at the beginning, is that you're keeping your elbow close to your body. You can just posterior tilt your scapula. It's really eliminating a lot of the other variables that can go a little haywire. So having your elbow close to your body, having your scapula posterior tilted and a little bit retracted creates a nice firm base of support. And now you can focus on just eccentrically loading that biceps. So keep in mind, same thing with all of the other talks. This is a pretty simple thing to diagnose. You, take a look at the actual evaluation, meaning what's the age of the patient. If I see someone who's 70 or 80, their entire arm is black and blue, this thing has already happened. It's already torn. It's already retracted. We can't do much about that. If it's someone young and they have a Popeye sign, this is not a days to weeks diagnosis. This is, hey, you have retraction of this. You need to see a surgeon now if you want it repaired. To be honest with you, I've never seen one repaired though. I always see them, kind of let them go. I think it's in my interpretation, it's probably more of a cosmetic injury than the insurance wanting to pay for it. But that's my opinion. I don't know that to be true. I think that looking at the patient's age and activity are probably the number one piece of this puzzle. The people that I have see keep their elbow in a slight elbow flexion. They don't want to let it go all the way out into extension. It's a guarding mechanism. They have a history of weightlifting, a history of repetitive stress, and then they don't like to even get into elbow extension. The two guys that I know, one that I saw have an actual rupture, he was never actually able to regain elbow extension, a terminal elbow extension. So I think that there's a big part of this that, one, it's an injury, but two, it's due to repetitive stresses, and it's up to us to recognize it early and hopefully get these people out of pain. In recap, I still think it's very important to look at this like impingement syndrome, often coexisting with impingement syndrome. However, when you have a tendinosis, meaning an irritation there, think about roughing it up, doing some strengthening. If you have a tendinitis, be nice to it, ice it, microcurrent. Don't compress it, don't sleep on it, that kind of stuff. So hopefully this helps as far as a primary biceps tendinopathy. If you leave it there for a long period of time, you can get more of a tendinosis, but also we see a lot of this in conjunction with a SLAP lesion. So the next couple of talks are going to be TOS, and then also we're going to get into adhesive capsulitis. So if you haven't looked at the seminars yet on upper cross syndrome, scapular dyskinesis, rotator cuff syndrome, check those out in the future. Otherwise, let's kind of jump right in to the next talk.